The only indication for ECMO in ARDS is refractory hypoxemia. If it is non-cardiogenic, then patient receives venous ECMO. However, if it is a cardiogenic process that is driving the refractory hypoxemia, then we will require what we call as VA ECMO. This is a very simplistic way how to decide what ECMO which patient will get. So this is true for most of our ARDS patients, including COVID-19 ARDS. So how it actually helps? So it prevents barotrauma, it prevents volutrauma, it prevents arterial trauma, it prevents oxygen toxicity, it decreases the driving pressure, which improves mortality. All these are possible because we can give our patient what we call as an ultra low lung protective ventilation. So because you're using a ultra low lung protective ventilation, how we decrease the barotrauma? By avoiding high airway pressures. How we avoid volutrauma? By avoiding a large tidal volume. How we prevent atelectrauma? By having a moderate PEEP without significantly increasing the airway pressure. How we decrease the oxygen toxicity? By decreasing the ventilator oxygen requirement. And because all of this, the driving pressure will decrease, which will improve the survival of the patient. So this is how the ECMO actually helps our patient, right? So how to select patients for ECMO, right? So this is called the very popular Murray scoring system. It has 4 components: 1, 2, 3, 4. So chest X-ray quadrants with consolidation is number 1. Depending upon the number of quadrants involved, the point will be given either 0.1, 2, 3 or 4. Hypoxia, which is measured as PF ratio, depending upon the PF ratio mentioned here, patient will get a point. Depending upon how much PEEP you are requiring for your patient to maintain a saturation of more than 90 or PO2 of 60 to 80, one scoring will be given. And compliance, you can calculate from the ventilator using a pause method, and depending upon your compliance, it will be given a number. So how to calculate the Murray score? So sum of individual components divided by 4, right? So if the score is 2 to 3, consider ECMO, because when the score is 2 to 3, mortality is more than equal to 50%. So consider ECMO. If the score is 3 to 4, ECMO is indicated. Why? Because here mortality is more than 80%. So this is the how you choose your patients to ECMO, provided there is a bridge to meaningful recovery. Second, only one organ system failure, that is the lung. If patient is having multi-system organ failure, in that case their mortality is even very high. So it's not worthwhile to put ECMO for those patients. So if only one organ system, that is the lung, has failed, it's good to put ECMO, right? And third is no contraindication to heparinization. As you've discussed, heparinization is must. So if patient cannot be given heparin, it's better not to put ECMO, because there will be thrombus formation and the ECMO efficiency will decrease, the circuit will clog, and there will be multiple complications. So if patient cannot given heparin, I think it's better not to put the patient on ECMO, right? Patient who are on mechanical ventilation, the mechanical ventilation duration should be less than 7 to 10 days. The earlier the better, because after 10 days of mechanical ventilation, all this has been done. Barotrauma has been done, volutrauma has been done, atelectrauma has been done. There is significant oxygen toxicity, there is high driving pressure. The mechanical ventilation duration should be less than 7 to 10 days. So what are the 4 conditions that has to be provided? First is the disease condition of the patient is reversible. So we are just putting the ECMO as a bridge to meaningful recovery. And there is only one organ system failure, that is the lung, and there is no contraindications to heparinization, and make ventilation duration less than 7 to 10 days. So these are the patient, they will go into ECMO. So while the patient put on ECMO, what are the things to set in the ECMO machine? What are the things to set in the ventilator? What are the things to look out for? How to troubleshoot any problem? We'll discuss in our next class. Thank you very much.